Good morning, everyone. I am Sarah Diaz with the California WIC Association, and I'm here with Dr. Jane Heinig from UC Davis Human Lactation Center and Robbie Gonzalez-Dow from the California Breastfeeding Coalition. And we're here to talk about the annual report of the California in-hospital breastfeeding data and fact sheets. This is the 8th release. And so we're excited to share with you what's been happening this year and talk about how data is changing the landscape of the breastfeeding scene in California. And you'll see the last bit, it says type your questions into the question box. It's actually called the chat tab. And so over on your right-hand side, I think you should see a little box that says chat. And underneath says organizers and panelists that you can send messages to. So if you have any questions, please type them in there and we'll answer them as they come in. So what we're going to go over today is the overview of the hospital breastfeeding fact sheets for 2016. Dr. Heinig's going to talk about the data and break it down a little bit for everybody, talk about what areas of the state are doing well and which not so well, and how things have improved. Feel free to ask questions as she's speaking, and I'm sure she'll get to them. We're also going to hear from Robbie about media outreach and talking to the press and how to get the message out there about how California's been doing, and review media strategies, talk about what materials will be available to you. So like I said, it's the 8th release. It includes statewide and county fact sheets, and it's a collaborative effort. Just for this webinar and the reports and fact sheets, it's CWA and the Human Lactation Center at UC Davis and California Breastfeeding Coalition, but there are a lot more organizations involved in the collection and dissemination of the data. As you can see, some of them listed there. And I think now we're going to turn it over to Dr. Heinig to talk about what the data actually says this year.
Good morning, everybody. I hope everybody can see my screen. This is Jane Heinig at UC Davis, and I can't see who's on the call, so I don't know how many of you have been through many of these calls and how many this may be your first. But this is our 8th release of a report that started quite a long time ago in California, and we're very proud, along with our partners, that this opportunity to share data publicly and the drive locally and statewide to change policies in hospitals has been extraordinarily successful, and we all have a lot to be proud about and a lot of work still to do. So as we said, we've been doing these reports since 2006, and it's been these reports have been produced in collaboration with the California WIC Association, and their vision of using data and combining data with other efforts to drive change in California. And in 2016, we have a full report again. Sometimes we have years where we just do the fact sheets, either at the state level and the county level. But this year we will have a report specifically focusing on how data have been used and continue to be used to drive policy change in California, actually across the nation. So data actually are used in a lot of different levels. And while data probably are not the most exciting thing to talk about, it is really important that people recognize that the availability of the data themselves has made an extraordinary difference in California and really nationally, because when data are visible, when people can see what the data look like, they tend to be more likely to take action to address issues that are brought up by those data. And so it's a really important practice to make data public, to use data in ways that can help people who are trying to advocate for policy change to be successful. So in most places now, and we live in a world, especially in the hospital world and medical world, you really do need evidence to show that there's a need for policy change. So data can be used, excuse me, data can be used to show that the policies that you're trying to advocate for, particularly baby-friendly hospital policies or similar policies, actually do result in increased breastfeeding rates. And those data have been available for decades, which is really quite an extraordinary thing. And I know I've said this a million times, but in so many areas of public health, you don't really have the opportunity to know what actually works and to have a wide evidence base to show that some action that you're attempting to advocate for actually works. And that's been one of the most important factors about the work that's been done in California hospitals, is that the evidence really showed that if you have policies that are the baby-friendly policies or similar policies, that you will actually increase exclusive breastfeeding rates among all the patients and all the moms in the hospital. And that really is an important fact that was needed to be shown to everyone before this whole process began. Also, data can be used to highlight disparities, and while the successes have continued in California, we still have disparities based on race, ethnicity, and those and regional disparities as well. And so that work must continue. We're certainly not able to sit back yet. There's a lot more work to do, and in targeting regions and populations that are still not getting the support they need will be an important aspect as we move forward. Also, data are often, especially on the hospital level, needed to obtain that administrative support. If the hospital administration doesn't see a need to move forward because they think their rates are okay and their rates are not, the data can actually be shown to the administration to show that, no, there really is an issue here and we need to work on it. And that's actually been a thing that really happened over this last decade, and it's been quite extraordinary to see the changes that have happened in such a large and diverse state like California. Data are used all over the place by many public health agencies to use as goals. Certainly the Healthy People 2020, the CDC goals, and the report card. They use these national efforts to show where we are in public health and where we should be in public health. So data can be used as powerful drivers in a very large way across the nation and in California. And also data can be used to fight misinformation. There was a lot of, when we started out, there was a lot of people who may have thought that certain populations would never exclusively breastfeed in the hospital because that was a cultural practice or a norm that there would be mixed feeding as early as the first few days of life. And what we've been able to show is that if there are supportive hospital policies in place, all moms in those hospitals will, who decide they want to breastfeed, will breastfeed exclusively. And it was a way to fight that misinformation, that it wasn't policy driven, that these mixed feeding rates were culturally driven, and we've shown over and over again that that's not the case. If moms are supported and they do wish to breastfeed, and that's why we focused on the gap, which we'll talk about in just a moment, we really were able to show again and again that all moms are going to breastfeed given the support to do so. So how has it worked in California? Well, the vision of the California Department of Public Health to decide to, quite a while ago now, to have the public surveillance data include infant feeding, both exclusive and any breastfeeding. That was really a remarkable decision that was made all those years ago. The decision was not made to ask, well, how are you breastfeeding your baby, but it was, the question was asked in a way that allowed us to look at any versus exclusive breastfeeding in the hospital. And then another decision was made to actually make these data public at the hospital level. And there aren't a lot of data available like that. So we were also partnering with all of our local representatives, California WIC Association and the Breastfeeding Coalition, to highlight the data for the media. And while at first, there was a lot more exposure, the media attention that we get is really evergreen in terms of the reports can pop up on a local basis all year long, and it's still driving change in the local hospitals and local areas. Data also were used by both the state and the advocate groups to find focus areas. So the state decided to focus in on looking at those lowest performing hospitals and provide training for them. The First Five organization saw what was happening in Los Angeles County and decided to focus some efforts with their funding in Los Angeles to improve things there. So it really has been used to identify areas and populations to target to increase the support for those areas. And also breastfeeding has been able to, so breastfeeding data have been used to help collaborations, help consortia work together towards a common goal, which is a lot of what the big public data like Healthy People 2020 and the CDC work is, to attempt to show people where they could go if they just figure out how to work together. And it's really quite amazing how well groups have been working together in California for a long time. And I think I always remember back many, many years, there was a wonderful doctor in Los Angeles who had shown that in her hospital, which was among the worst and lowest performing hospitals for many years, that they were able to increase their breastfeeding rates by changing their policies. And I remember her saying, if we can do it, anybody can. And I think that it is important for people to see, using data, that change is possible. And it makes it harder for people to be resistant to change if they see another organization, another hospital, another group making changes that may have been started off worse off than they were. So I think that data can be really powerful. And all this working together keeps everybody energized, keeps everybody moving forward, and makes it possible for the changes that we've seen in California. So if you're not familiar with the genetic screening, then this is what this is about. It's just saying that all moms who are giving birth in hospitals are asked at the time they do the screen for the newborns, they do the blood draw, excuse me, for the newborn screening, how they're feeding their babies. And in California, we do have this option of only human milk, only formula, or human milk and formula. And because of that, we can see how many moms are mixed feeding at that point, how many moms are exclusively breastfeeding, and how many moms are exclusively formula feeding. And really, in California hospitals, exclusive formula feeding is quite rare. So we're fortunate about that. So most moms, an extraordinarily high number of moms in California, are trying breastfeeding in the hospital, indicating that they do want to breastfeed their babies. And because of that, we want to make sure as many of those moms as possible are supported to do so exclusively. Because even if they are going to mix feed their babies down the line for their own personal, or perhaps they have to return to work or whatever their situation is, and that obviously we have laws in California now that they shouldn't have to mix feed their babies, but for whatever reason a mom may choose to do so, she still needs to exclusively breastfeed early so that she can have that breast milk part of that mix. But we do encourage that it's now possible that most moms can exclusively breastfeed, and want to encourage that to happen. So the data are reported by CDPH, and working from newborn screening and into maternal child adolescent health program that does a lot of data cleaning and reporting, and that those data are made available to the public, and then we can use them here at UC Davis to highlight some of the features, because they do come out in Excel spreadsheets, which aren't always that accessible to people. So we try to make the data a little bit more accessible. So what do they look like now? What are the hospitals looking like now? Well, what's really amazing is that for those of you who this is your first time you've ever been on one of these calls, then this may not look that remarkable to you. But for those of us who have been around for a long time, these data, even this particular slide, is pretty amazing, because when we started this process, a decade ago, the gaps, especially in the Central California and Los Angeles, were really large, really big. And so what are we talking about the gap? The gap is the difference between the any breastfeeding, that would include moms who had reported that they were giving breast milk only, and the moms who were giving breast milk and formula. So that's the any. That means they're providing any breast milk at all. Then the blue is looking at the moms who only reported that they were giving human milk only. So that's the exclusive breastfeeding rate. And you can see that there's a gap between these two. And that gap is related to the supplementation rate in that hospital, very highly related to that supplementation rate in the hospital. So really the focus has been of these reports and work by other organizations, even before these reports were released, to narrow that gap as much as possible. Now, it's never going to be zero. The gap is never going to be zero in a population level, because there will be medical necessity for supplementation for some babies. But we were in a world where enormous numbers of babies were given formula supplementation in the hospital, especially in the Central Valley in Los Angeles. And now that these gaps are closing, they're starting to get closer and closer, probably to the limit of those gaps and what they're going to be in the end. But it's pretty amazing how much these gaps have closed over time. So what we've seen since 2010, and there were data changes in how the data were collected that really settled down in 2010. So between 2010 and 2015 is what we're looking at, because 2010 became sort of this new baseline. And even in this period of time, we've seen a 12 percentage point increase in exclusive breastfeeding in California hospitals as a whole. And while for some people 12% may not sound a lot, but we're talking about a very, very large and diverse state, and having this kind of effect of policy change really is extraordinary. We're talking about, you know, tens of thousands of families now breastfeeding exclusively, which they probably wouldn't have been doing in 2010. We also can take a look at the gaps by race ethnicity, and this is actually a graph that was that used the 2010 data, just to show you how wide some of these gaps were in 2010 at that new baseline level that we had then. And you can see that there's great disparity in what those gaps look like based on race ethnicity. Now let's look at 2015. And while there are still disparities by race ethnicity in California in terms of this gap, you can see that these gaps are closing, and closing pretty rapidly. And so it really is showing that the effect of the policy changes in California are influencing exclusive breastfeeding rates among all women, no matter what race ethnicity they are, which is really important, because you want to make sure that if you're making changes in public health that you're improving the situation for all women, not just for specific groups. We still have a lot of work to do, because there are women who are still not receiving the support they need to exclusively breastfeed, because these gaps, you know, remain large in some of our populations. But we really feel like we are on the right track, and that we can continuously make improvements as we move forward from here. This is just a graph very specifically showing the changes in exclusive breastfeeding between 2010 and 2015. It's sort of like the last graph, except removing all the any boxes, so that any columns, sorry, so you can see what the increases have looked like. And you can see that the increases are across the board. There's no population in California where they haven't seen increases in exclusive breastfeeding, which is a really important thing. But we do need to keep going. We need to keep working so that we don't have disparities in exclusive breastfeeding rates at all. And still, despite the work that's been going on, we still have these regional disparities where we tend to still have the highest breastfeeding rates in the northern and mountain and coastal areas. The slide changed hardly since the beginning of this whole process, and the lowest rates still exist in the southern and central valley. But it's really important that everybody recognizes that even though the highest rates are in the same places and the lowest rates are in the same places, the rates themselves have changed dramatically. So everyone is moving upward, everyone is improving, but the disparity is still in there, because some of these rates in the lowest regions before were so low that it's going to take some time to catch up, and continuous effort to catch up. We can't give up, we have to keep going. And there really has been amazing work done by local coalitions. First Five in Los Angeles County and other funders are really working hard to close the gaps. And it's been amazing to see all these changes in such a large, large state. And this graph, I think everyone in Southern California and the Central Valley should be extremely proud of. This is, again, showing only the exclusive rates, so there's no any rates here. And you can see the 2010 in blue and the 2015 in gray, and you can see the extraordinary change that's happened in these Central Valley and Southern California counties. So the work that everyone's been working so hard in these hospitals and working to make these changes, and you can see that the data are showing that, hey, they've done a great job. We can continue this work and continue to see these changes happen. And most of you who are familiar with our reports know that we also have done the good list and the bad list, which was really highlighting the highest performing hospitals and looking at their any and exclusive rates, and also the lowest performing hospitals in California. And so this would be what the gaps look like in our high performers, and this is what the gaps look in our bad list, I guess we call it, or the lowest performing hospitals. And while these gaps are quite large, and the gaps need to be addressed by policy change, no question about it, some of these hospitals have worked very hard already and are continuously working already to make their rates, their exclusive rates increased. And the list as a whole has really made it harder and harder to find hospitals that are in this low-performing category if you were using the same criteria that we were using even a few years ago. So what I mean to say is that most of the hospitals on the list now wouldn't have made the list because there were so many poorer performing hospitals 5 or 6 years ago that now we're seeing our low performers having rates of exclusive breastfeeding in the 40s, which would have been not anywhere near what they would have been 4 or 5 years ago. And of course, everyone recognizes how rapidly we are increasing our baby-friendly hospitals in California. And of course, we now have a law that maternity hospitals in California are going to adopt policies, either baby-friendly or similar, by 2025. And so it really is incredible. When I go to other states and I talk about that we have a law now, most people, their jaws just drop. They can't believe that that was even attainable. And we really are leading the nation and showing people that you can make change in even a very large and diverse state, then they should feel they can make changes in their states as well. So just to kind of remind everybody that in California, we're quite a special group here because of what we have and what we have access to and the kind of partnerships that have grown around the breastfeeding advocacy that happens in California. So most people think that those hospital level data are probably available in every state, and that's not true at all. There are many states, and very few states, in fact, where these data are available. So having the data the way that they're reported and publicly data reported at a hospital level is an extraordinary opportunity for advocacy, and we always have to congratulate CDPH for continuing this effort. Also, we have been focusing on that exclusive breastfeeding measure and the gap between the any and exclusive. And that, I think, has been important because really, if someone has started breastfeeding in the hospital, I mean, sometimes when we first started these reports, people would say things like, well, you are trying to force women to make choices, but that's not true at all, because women who start breastfeeding obviously want to breastfeed, and so we just want to make sure that they are supported to do so exclusively. And California now has 22% of all baby-friendly hospitals in the U.S. And while we used to be higher, the reason why we're not higher than that now is because there are so many more baby-friendly hospitals in the U.S. So we're really happy to see the progress nationwide. And a lot of other states do look to us as the leaders to show what can be done to improve policies. But we do have an ask. We still have an ask here in that our success has been driven by these nearly universal public in-hospital data. So having the availability of these data has really been able to move us forward. But we don't have similar data available to improve breastfeeding rates after discharge, and that really is our new frontier, I think. And that there are data collected by federal and other sources, but they're limited and they're collected in different ways and at different time points, and that makes them harder to be compared. And if you can't compare data, then it's really hard to get a picture of what's going on. So even though it's kind of boring to most people to think about data, and it's a big ask to see if we can figure out how to advocate for consistent and comparable data, to build on these successes in the hospitals and get them the data available on post-discharge data so we can improve duration and exclusivity of breastfeeding and also improve maternal-child health in doing so. So this year, we really are describing the data. So again, it may not be the most exciting thing to some people, but what's been happening in at UC Davis and California has been pretty exciting about how we've been able to move things forward in terms of looking at these data and making change in the local and regional national levels. It's pretty amazing. And to describe the benefits and challenges of using the surveillance data, because I know a lot of people are always concerned about the accuracy of the surveillance data. And so we describe more about that and why surveillance data are still really important to use despite their limitations. Then we describe successful use of data and the need for consistent and comparable data after discharge. And then we include our recommendations for data collection and other efforts to build on the momentum that we see in California. So in the fact sheets, pretty much the same thing we've done before, where we're doing the background and we're describing how the data have been used, and includes the county rates and the ranks and the baby-friendly hospitals and the highest performing hospitals and the lowest performing hospitals. if they're in that county. And also on the state fact sheet, we'll provide the background and then the lists, the statewide data by race ethnicity, the county rankings, and the recommendations. So that's all I have to add, and there's our contact information if you have questions. And I know that everyone always refers to me should you have some sort of complicated data question that is challenging to answer. And we'll be available here when the report is released to answer those questions to support you if you're trying to provide information to the media. That's it for me. Thank you.
So just a reminder, this is Margaret, just a reminder to for people to type their questions that they have in the chat box, and we'll do that. And I'm going to turn it back over to Sarah.
Thank you, Margaret, and thank you, Dr. Heinig, for sharing that with us. It was really encouraging to see how much better things have gotten. So now, we're going to talk with Robbie Gonzalez-Dow about how we can get the word out and share that encouraging information with our media partners and make sure that people are aware of how much things have changed and how we can help things continue to change and how data drives the policy that help things change.
Thank you, Sarah, and hello to everyone. I hope the message is encouraging when you see the data and what Jane has just shared, because to get the word out, we need you at the local level. We have the surveillance data, we have it statewide, but we have it by every county and every hospital, and it's so powerful when you can use this at the local level. So I'm going to talk about making the pitch, because we really do need to have a grassroots effort to get the information out. If we don't make the pitch, nobody else will do that. We're the ones who, the breastfeeding advocates, know the importance of this data. So I'll just talk a little bit about making the pitch. It can be scary. Even when I call a reporter, my heart starts to beat and I get nervous. But if I'm not the one to make that call, nobody else is going to. There could be somebody else in my area, but us as advocates, we really have to move that forward. So I just want to practice a little bit like what I would do, but I'd sit down, maybe have some water, I'd have my sheets in front of me, but I'd also identify who could I call in my community. Who are the reporters that usually cover health issues? And then, so I would, here in Santa Cruz County, I know that there's a reporter, her name is John D., and she covers a lot of health issues. What you'll notice is that the reporter, I guess, workforce is really shrinking at newspapers. A lot have, they have cut down the number of reporters and the number of papers. In our area, sometimes we get articles that are from the San Jose Mercury, so they're not even necessarily local, so there's a lot of shared media. But look through online. It's easy to look online who's covering the health issues in the paper. You could get a hard copy paper, but you could also look online. What I do sometimes, because I get Google alerts, and I'll notice a local, maybe there's an article in Kern County, right there. So our most recent baby-friendly hospital was in Kern County. So right away I looked at who that reporter's name who had that article and jotted it down, because then you have their email. And so you can have pretty easy access to them. And you could call the paper to find out what the phone number is. But you could always start with an email, just an intriguing email. Just, hey, have you seen this new report? It shows hospital level data in our county and shows how some of our hospitals have really good breastfeeding rates, some of the hospitals don't, and there are reasons why. Could I have a minute to talk with you about what's going on in our community with breastfeeding rates? And Santa Cruz County, Kern County, Sacramento County. But when you're calling, you could do the same thing. So I would say, hi, John D. This is Robbie with the Santa Cruz Breastfeeding Coalition. And the hospital breastfeeding rates report has come out. And we're seeing some definite changes here in Santa Cruz. And I wonder if you have a minute that I can share this with you. So she might say yes, no, and sometimes she goes right into a question. Well, what are you seeing? The nice thing about it is we've built a relationship with her, and so usually she usually will have a question right away. So you might have a little bit of some preparation in that. The other thing you can look through are the blogs on the newspapers also, and then the same thing with knowing who your reporters are on TV. And we'll have a sample press release that you can use to send to TV stations. So I'll go to the next slide, building on the messages that Jane mentioned. These are some of the ones that we had last year which are still relevant. So you could take some notes here, but it was also the talking points were on the 18th slide that Jane had when she talked about gaps in data after discharge, because that's also a key message, kind of our ask. And you will have access to those slides. So as we go through these, when you're talking about key messages, we want to focus on the hospital policies. That's what has resulted in increased breastfeeding rates among moms, the initiation, duration, exclusivity. And if you can put this key point down, it's not on the slide, but that in California we continue to improve the breastfeeding rates because we have an increasing numbers of hospitals that are making the policy changes. Those policy changes are becoming baby friendly. So depending on your community, if that's a change that still needs to be made, you don't have very many baby friendly hospitals, or they're on their way but no one has become designated, or you have 2 left or 3 left, this would be a key message because the rates will reflect how far along the hospitals have come along in terms of making those policy changes and becoming more baby friendly. So the second one is, it's still, oh, no, keep it there, that these breastfeeding rates, they lead to improved health outcomes for moms and babies, and particularly in obesity prevention. The other thing that you want to add there is that the availability of the data is driving these changes, is driving these health outcomes. So the data is really important. You can highlight those with the fact sheets that we have. So you want to share those fact sheets. And then that consistent comparable data are needed to drive change in post-discharge breastfeeding rates. So this is kind of a springboard. We know the hospitals all have to make the policy changes because of the law, and you can reiterate that, but that now that we move further and we see that there are disparities, that we don't have the same exclusive breastfeeding rates in long term for all of our moms, and we need a way to track that. And so that's going to be a message statewide. So think about when you're working with your local breastfeeding coalition and with your partners, or particularly your WIC program, they share some data with you. So for instance, what I could say in Santa Cruz County is we have one hospital that hasn't been designated yet, and they're almost there, Watsonville Community Hospital, and I could even have ready a contact for them to speak to somebody there, to speak to the media on their progress. Say they've made progress. As they become more baby friendly, they have seen an increase in exclusive breastfeeding rates. So 5 years ago, so 2010, their exclusive breastfeeding rate was 53.4%, so 53%. And in this report that we're looking at now, Watsonville Community Hospital has 89% exclusive breastfeeding rate. They have increased by almost 36 points in exclusive breastfeeding because they are making the policy changes to support moms who come into the hospital and want to breastfeed. So they're closing the gap because they have almost 98% of the moms who want to breastfeed. They initiate breastfeeding in the hospital. But what we're seeing in our community at our WIC program is by 2 months, only 40% of the moms are still exclusively breastfeeding. And so they may ask, well, what's going on? So it depends in your community what you see as some of the factors that are impacting breastfeeding. So for us, I might tag on to the systems that we're working on ensuring. So what are the laws that we need to support? We're working on ensuring that all employers are complying with the state and federal laws to support moms in the workplace. There's still many employers that don't know that that's a requirement, and moms need support in the workplace. We hear that from moms that they're not experiencing a supportive workplace, and they're afraid to go back to work and to continue to breastfeed. So you can use it as a kind of a springboard, or also that we need comparable data. We don't know what the long-term breastfeeding rates from healthcare because it's not collected in a consistent way. So we will. I'm not sure if there are any questions. Feel free to chat in any questions. But if you want to go to the next slide. So just some tips, media tips that we've learned along the way is to be prepared. And it's okay to say, if they ask you a question, let me get back to you on that. I don't have an answer for that right now, but I can get that. Keep your fact sheets handy. You might want even just to talk to someone within your organization or within your coalition to talk about the data and just speak out loud about it and sharing it and practice that pitch. We will have a set of talking points so you can review those, but localize them. I think that's important too. What's going on in your community? What do you see as the barriers that are impacting duration of breastfeeding? And just keep it simple. I'm not sure if any of you have attended the summit a few years ago when Kellogg Foundation was there, and they shared a little booklet with us on some key messages. And that little booklet had some really good short little talking points when it came to some of the other barriers. Like I've used the ones on employment a lot, or workplace. They have some on healthcare. But just keeping it simple. What we hear from moms is they're not being supported in the workplace. So it's really important that employers follow state and federal laws that require them to provide a private space and time for moms to pump while they're at work. Just something like that. One key thing is to focus on the policies, not people. I notice sometimes that reporters want to say, well, why is it that Hispanic moms aren't breastfeeding as much? Or African American moms, what's going on with this population? And so you kind of have to shift it so that it focuses on the structures, the systems that people are placed in, versus that it's something about the culture that's wrong. So find people in your community who can speak to that if you don't feel comfortable to talk about the systems, whether it's workplace or our moms work in jobs where they don't get paid family leave. Maybe that hospital still isn't baby friendly, or they haven't started yet on their process to become baby friendly and change their policies and practices. Maybe there's a higher teen birth rate among a population in your community, and the schools haven't yet implemented the policy to support teens at school with pumping so that they can continue to breastfeed. So think about the systems and that people are placed in that are the potential barriers or the real barriers to why that culture, the moms aren't breastfeeding. So policies, not people. And I had mentioned it's okay to say if you don't know, to get back to them and if you're getting a call from a media person, they may want to jump on this, so just be aware of their deadline. So you may get a call and be the resource to them. So find out when they usually want a pretty fast turnaround. So if you think about who can be the spokesperson in your community, who are people you could call upon to give an interview, but think about this as a countywide effort, and maybe with your coalition, that would be a good strategy. The next slide. I do want to mention, so again, I had mentioned that we do have some personal relationships with local media. So that is, if, let's say you're like, I don't know anyone. This is a great opportunity to start meeting some of those local media people. As I had mentioned, the person in Santa Cruz County, they've actually many, many years, and so there hasn't been a lot of turnover. I noticed even like in San Joaquin County, ever since we've been doing the report, there's a reporter there, and I think his name is Jeff Golding, something like that. I don't remember his exact name, but I'm like, okay, he's going to get this because he's the same reporter in that area, and he's most likely to cover it. And now in some places it's becoming a really positive story too. So start building those local media relationships. Again, I had mentioned this can be your local breastfeeding coalition effort. Maybe different people within your group have different expertise and can play different roles or represent different parts of your community, and they could also be spokespeople. You may have some local decision makers, or you have a key contact at First Five or your county health director. They would be good spokespeople also, and bring them into your fold, into your coalition to support this media advocacy effort. And then there's also social media, your Twitter. And I don't know, Sarah, if you want to mention anything about this. If we'll have a few like pre-written blurbs that we can post.
Yeah, we're planning to release, when we release the media alert and the press release and the talking points, we'll also have a small social media kit that people can use with like sample tweets or Facebook posts, and we're hoping to also have a few social media ready graphics that can be used on Facebook or Twitter or Instagram. And if you don't have a relationship with a media person already, but you're aware that they have a social media presence, you can always use that opportunity to tweet at them. A lot of reporters have Twitter accounts, professional Twitter accounts that they're pretty active on, and so that's another way to reach people.
That's a great idea. And just try it once if you have never done that. This is a relevant way to jump in and try the tweeting, or I'm not sure if we have a special hashtag for this.
We don't, but that's a good idea. And when I release the social media kit, I can come up with one by then. And if anyone needs a little walkthrough on tweeting at somebody, I can help you with that too.
With the California Breastfeeding Coalition, we have our Facebook linked to our Twitter, so anything that goes to our Facebook automatically goes to Twitter, so it looks pretty active. What I do notice is you just have to put one little short comment, otherwise it will just show like a little link. So putting a one-liner comment is helpful if you have them linked. It makes it more interesting, more likely for people to look at it. So in our with our media markets, if you are in Sacramento, the Bay Area, in Fresno, you could go to the next slide, Sarah. The Central Valley, Los Angeles, or San Diego, those are the 5 big media markets in California. But really, anywhere is great to get any kind of news. They do show up on the Google alerts if, I have mine set like if there's breastfeeding or baby-friendly or maternity care. And those littler papers will be picked up. And we repost them and put them on social media. But if you're in one of these bigger media markets, if you can help out and reach out, that would be great. Before we go, we have so everything will be posted. I think we have a timeline. I think we want to talk about the embargo, but I do want to say that just in terms of the data, on the first day of the summit, we are going to be discussing data. So I just want to put a little plug in for that, but on addressing disparities, because that's where we really do need to dig deeper in our communities, what's happening in our specific community, so that we can address disparities and support all moms in our communities. So I would encourage you to look at attending that day one, because it will be about using the data or generating new data so that we can find out how to support all of our moms in our communities. So the report is embargoed until October 19th. Sarah, did you want to talk about that?
Yeah, I think I somehow missed that slide. Oh, there we go. Okay, so the fact sheets are going to be, embargoed fact sheets will be available after October 19th. So you'll only be able to see them if we send you the link. So if you need the link, you can email me to request it. And then the official release will be on October 25th. So we ask that you don't share them until October 25th, but you can use them after the 19th to review them and sort of drill yourself on the data so that you can answer questions and put together any statements from local community partners that you think would be useful for the media. And then the media alerts and press releases will be available through us as well, and the social media kit I'll have for you, and some talking points. Do we have any questions? I'm not seeing any questions on the little chat box, so I hope it's working for people if you're trying.
I would just like to ask Jane, because I know she does get interviewed quite a bit, if there was anything else that you found reporters tend to focus on that might pull us away from the key messages.
I think that sometimes there'll still be that echo of that belief that certain populations don't breastfeed or don't breastfeed exclusively. And I think that the way you described it was perfect. You just keep bringing people back to the situation that people are in, and keep focusing on that. But that's actually less than it used to be. I think we're real fortunate that way. I thought your news about Watsonville was amazing. I'm really excited about that. The exclusive rates are so high. That's just amazing. Amazing.
It is exciting, and even though I made it sound like 40% exclusive breastfeeding rates at 2 months was poor, because I was comparing it to initiation, exclusively at initiation, it has gone up. That used to be 10 years ago 22% at 2 months.
Right.
So,
but I think that it does echo that same point, in that we really do need the data available after hospital discharge to really track what happens to these moms that are these very nice high rates of exclusive breastfeeding during that hospital stay, and then they leave the hospital and then the rates drop. Why is that happening? Where does it happen? And we really need those data to make that understandable and to help people know what to do in each environment.
And I wanted to add too, when you we're talking about the hospital in Watsonville and how amazing that change was, that if people want to look at their local hospitals and what the change has been like, older reports and fact sheets are available on CWA's website so that you can check out the hospitals in your county and see what they were 10 years ago.
Yes, and certainly what everyone has learned is that for the media especially, the local story is really what's important. So by taking a look at those older reports and then looking at the new fact sheets, you'll be able to make that same comparison that Robbie did, and you can inform your local media how things have changed or not changed in your environment. And that's what people are really going to be focused on in these in the regional media markets.
So this is Margaret, and a question did come in via the question box. I'll read it to you. From Jean Kettles, she's asking, have the local health officers had this report shared during the embargo? It would be nice to have them in the know before promotion.
I think that's a Sarah question.
I think that might be a Karen question. Hold on just a second. We'll get back to you.
Okay.
You know, I guess, Robbie, that they haven't, but it's something that we could ask the department to send out. That's a good strategy.
Yeah, it seems like
Yes,
a good fit to me, but I don't think we've done that in the past, so that might be really good.
Good suggestion.
I actually have I'm going to be seeing Connie Mitchell this Friday, so this is something that I can ask her, because then they could reach the person who works with the health officers.
That'd be terrific.
Yep.
Okay. Karen just noted that we have shared it with CDPH in the past, so I don't know if they would have shared it with health officers or not, but they may have.
Right,
Sounds
and
like a great idea.
suggestion is would be great, since she already has a meeting this week.
Yeah.
Terrific.
Great. No other questions?
Not that I'm seeing.
Well, our contact information is available, so if people have questions after the webinar, they certainly could reach us on the contact information, once the slides are posted, I should say.
Yes, and that will be by the middle of next week. So.
Okay.
And if it's earlier, we'll let you know.
Thank you, everybody, for joining us, and thank you so much, Robbie and Dr. Heinig, for helping present the data and the media tips and getting everybody ready for the release.
Thank you all.
Thank you.
Bye-bye.
Bye.
Bye.